Okay.
Great. Maybe we can get started with some introductions for the two co-facilitators, just wanting to stay on time to give all the speakers as much time as possible. Hello, everybody. Welcome to our session for the Health Equity and Anti-Racism Symposium. It's called Innovations to Advance Health Equity. They're great. Symposium. We have 7 great talks. I'm going to introduce myself. I'm Dr. Alka Kanea. I'm a professor of medicine. I'm a general primary care internist at Mount Zion. And I am so happy to be here. And I'm co-facilitating with Cecile Puretz. I'm going to let Cecile introduce herself.
Thank you so much, Alka. Hi, everyone. My name is Cecile Puretz. I serve as the Assistant Director of Disability Access and Inclusion at UCSF. And this is actually an inaugural office. It's been around a year and a half. And I serve with the Chief Accessibility and Inclusion Officer, Wendy Tobias. So I'm thrilled to be here and look forward to your presentations.
Great. So the format is we have 7 posters that we're going to share screen and show your posters, and there will be a timer at the bottom, which gives you 5 minutes to speak, to go through your poster, and we'd like to save 2 minutes after the poster for any questions and discussion. And so we'd like to start out with the first poster is poster P02. Cecile will share screen, and the 3 presenters are Amina Ng, Gea de la, oh my goodness.
Gea de los Reyes.
De los Reyes, I'm so sorry. And Jasmine Valencia, and the name of the poster, the title is Evaluation of a Pharmacy-Linked Smoking Cessation Intervention for Adults Experiencing Homelessness. Take it away.
Just a moment, I'm actually going to jump to that presentation.
Yeah, they weren't placed in order in the poster box. It's P02.
I'm sorry, Alka, can you say the presentation again?
It's P02, so that's P20. Keep going.
Okay.
It's evaluation of a pharmacy-linked smoking cessation intervention for adults experiencing homelessness. Yeah, that's it. Terrific, you can start.
Hi, everyone. Thank you so much for joining us today. So we conducted this research because past findings show that over 60% of people experiencing homelessness who smoke attempt to quit smoking yearly. However, they are less likely to quit successfully, and most quit attempts are unassisted, highlighting the need for increasing access to treatment. Therefore, we conducted this pharmacy-linked smoking cessation program at 3 homeless shelters in San Francisco, California, that included a one-time pharmacist consultation on tobacco cessation and monthly delivery of pharmacotherapy for cessation.
So our study has 2 main objectives, which are to evaluate the pharmacy-linked smoking cessation program on the outcomes of cigarette consumption and quit attempts, and to also explore the barriers to and facilitators of engaging in such a program. In terms of the methods, for the first objective, we obtained information on tobacco use and quit attempts weekly for 3 months among people experiencing homelessness. And we also examined whether medication assistance and encounters with staff were associated with positive outcomes. For the second objective, we conducted semi-structured interviews with 8 residents, 2 staff, and 1 pharmacist on barriers to and facilitators of engaging in the program. And we used these interviews and analyzed them into themes of predisposing, enabling, and reinforcing factors based on the precede-proceed model. And we used this to evaluate how well the smoking cessation program met the needs of the residents.
So now just going over our results, our study included 51 participants who underwent study visits. About 65% attended all 13 visits, and on average, participants attended 7 of the maximum 13. As highlighted in Table 1 is the sample characteristics of the 51 participants. So for demographic, participants average a mean age of about 47 years old. 63% were male, 39% were white, followed by a third that identified as Black or African Americans. Overall, close to 80% reported experiencing chronic homelessness in the past 12 months. Moving on to Table 2, which conveyed the tobacco use characteristics at baseline, participants had been smoking about a median 8.5 cigarettes per day, with half indicating daily use. Over 40% had indicated an intention to quit smoking within the next 6 months, with more than half reported making a quit attempt in the past year. Shifting to figure 1, this graph highlights the average daily cigarette consumption over the 13-week period. And as you can see, we see a gradual decline over time in consumption. The average daily cigarette consumption was reduced by 55% from 10 cigarettes per day at baseline to only 4.5 cigarettes at the 13-week mark. And if we go down to figure 2, we have a graph that's highlighting the proportion of abstinence per week measured by carbon monoxide levels. And overall, 56% had carbon monoxide verified abstinence. Therefore, quitting seemed to increase as the study time period went on.
In terms of the qualitative data results, we found that for predisposing factors, participants had previous knowledge about tobacco use and experience with cessation. They also had beliefs and attitudes towards cessation. For enabling factors, they found the reminders, reinforcements, and social support to be very helpful. For the reinforcement factors, participants expressed desire for longer duration of the resources to engage in cessation and for on-site ongoing social support. This is a direct quote from one of our participants. I want to quit smoking, and it was a good opportunity to take advantage of the supplements, patches, lozenge, and monitoring. And there were other people participating.
Okay, and then in terms of our limitations, the study involves participants from only 3 navigational centers in San Francisco, meaning that the attitudes and experiences of the individuals may not be reflective of the general population. Our small sample size unfortunately makes it also difficult to generalize to other homeless populations. And to conclude, a community pharmacy-linked cessation intervention was found to lead to increased quitting behaviors among people experiencing homelessness. And these findings provide new information that can improve the provision of these services and potentially expand to other sites with the goal of increasing access and
Terrific. I think that was the end. We might have gotten cut off at the very end. Thank you so much for that wonderful presentation. We have about 2 minutes for questions, discussion. While you're all waiting to think about a question, I have a question. This was really very exciting to see such, great outcomes from this study, and I'm wondering about the differences in the use of the cessation medication and the efficacy of cessation medications in this population. You say that it was associated with a 29% reduction in consumption and 2-fold higher odds of quitting. Is that consistent with what we would expect in other randomized trials that have been done, perhaps in different populations? Thank you, Maya.
Yasmin and Gaya, you're welcome to also pass it on to me.
Yeah, would you mind taking this one, Maya, please?
Sure. I think we got cut off. So I just want to acknowledge the San Francisco Cancer Initiative for funding this work. It's been now actually 7 years that we've received funding from the initiative, and we've been doing this program for the last 2 years in partnership with shelters and pharmacies. So it's been a really rewarding experience. To answer your question, Alka, we wrote a Cochrane review on this topic in terms of efficacy of smoking cessation interventions for people experiencing homelessness. And the idea is that there should really be no difference in terms of, biology for why people respond to these medications any differently than people who are housed. So that we certainly, determined through the Cochrane review that the efficacy that we're seeing in randomized controlled trials in the general population, we see quit attempts of actually sustained absence of around 30 to 40% at 6 months follow-up. Here, we're not really looking at sustained abstinence. We are measuring quit attempts, and that seems very consistent with what we would expect in the general population. And I think the reduction in consumption by 50% is also very consistent.
Terrific.
So Alka, I'm going to bring us back into the stop sharing for a moment.
Yeah, sorry. I think it looks like the timer cuts people off right at 5 minutes. So is that may be what happened. So I apologize for the rudeness of the timer. And maybe what we can do is give you a 30-second warning or a 1-minute warning in the chat. Cecile, would that be possible?
Sure. I think I can do
that way it won't be as rude, hopefully startling. Great. Any other last questions before we go to the next talk? Thank you so much. That was a wonderful presentation and great results. Nice to share. We're going to go to poster number 70, Katarina Wang. Hi, everybody. Katarina, we're going to put up your poster, and the title of her poster is Correlates of Supportive Care Needs Among Asian Americans with Colorectal, Liver, and Lung Cancer, Findings from Phase 2 of the Patient Cancer Outreach, Navigation, Technology, and Support Patient Count Study. Take it away.
Great, thank you so much, Alka. So just some background on why this study is important. Cancer is the leading cause of death for Asian Americans, and Asian American patients' navigational needs for cancer supportive care are understudied. This is a unique demographic to look into because Asian American patients experience language and cultural barriers in their cancer care. So in response to this, our team designed Patient Counts, which was created as a web-based program to deliver culturally and linguistically tailored navigation to Asian American patients with cancer. And the objective of this specific project within the bigger Patient Count study was to examine the patient factors that were associated with supportive care needs of Asian American cancer patients in our study. So in terms of the methodology, we derived our data from the Patient Count study, specifically the baseline needs assessment data, which had an N of 47 participants. And for eligibility, we recruited Asian American adults that were diagnosed recently with stages 1 through 4, colorectal, liver, or lung cancer. And these adults would have to speak either English, Chinese, or Vietnamese. And in terms of recruitment, we recruited participants with the Greater Bay Area Cancer Registry. And this was a single arm pilot intervention. Patients were assigned to a language concordant patient navigator who was, spoke their language and was from a similar or the same cultural background. And they then the patients were enrolled in a web-based patient portal, and the navigators were able to provide resources for these patients through the patient portal. And we also conducted survey assessments at baseline 3 months and 6 months to assess the needs of these patients. So some key measures that this project reflects would be the patient factors. So that would be patient age, gender, ethnicity, cancer stage, English proficiency, language preference, education, employment status, and income, and also cancer supportive care needs, which I'll describe later. So in the needs assessment, patients indicated whether they had a specific need, either a yes or a no. And then we calculated an average standardized score to quantify the importance of each needs domain. And then in terms of data analyses, we also ran generalized linear models to identify which patient factors were correlated with the needs domains. So moving on to the middle column under the needs domains map. So there were multiple different questions in the need assessments asking if participants had a need for cancer information, for like cancer treatment, cancer diagnosis information, et cetera. So we grouped all these smaller questions into into four bigger domains. So we have the cancer specific information domain, the daily living domain, which includes food access, housing, which is pretty important for our participant demographics, and then language domain, and which is also quite significant since this was a group of Asian American patients, and then behavioral health domain. So moving in the middle column upwards to patient characteristics. So most of our participants were men, and our participants tended to be older, with a mean age of 57, and the age ranges were 30 to 82. Most had limited English proficiency, 34% did not attend college, and we had about half with lung cancer, about half with colorectal, 4% with liver, and a pretty even spread of stage. So in terms of the results, we see that cancer-specific information was the most prominent need of our population, followed by daily living, language, and behavioral health. In terms of the generalized linear models in the last column, we found that for daily living needs, lower annual income and being retired led to higher daily living needs. And then for language, participants who spoke Chinese or Vietnamese, and those who had higher language needs, and those who were retired had less language needs. And then for behavioral health, male participants had greater behavioral health needs, and younger participants had greater behavioral health needs. So in conclusion, we were able to look at the different correlates that were different correlates of patient factors and needs that these specific demographics had. And this is important for providing patient-centered care in cancer supportive care. And these findings will inform future interventions to improve the care that Asian American cancer patients receive. And future directions would be to just do additional analyses on the outcomes of the patient count study, and also talk about how we designed the web portal to inform future digital health interventions. Thank you so much.
Thank you, Katerina. That was wonderful. We have a minute or so for questions. I have a question. Were you able to tease out exactly what it was that was helpful in the navigation services? Are you looking at that with any qualitative data, any interviewer type data? Like what piece of that, if you could roll this out to every single organization that has cancer treatment?
Yeah, that's a really great question. So we have some qualitative, like survey questions that we'll report in the future study. But I think from my experience in this study, just in general, having the navigator be fluent in the language that the participant speaks was very crucial. And also this web portal was actually really helpful for many participants since they were able to access all of these resources that the navigators gave them online or on their phone. It was a challenge for some older participants, but then with the assistance of a caregiver, they were able to access the resources. So I'd say just like language concordance of the navigator, and just like being able to deliver the resources in an efficient and effective way.
Thank you. The pairing of having somebody who you probably get to touch with, and also the language concordance. That's really interesting. Any other questions? Okay, thank you so much, Katerina. That was wonderful. We'll move on to the third poster, which is poster number 75, presented by Janice Wang. And the title of the poster is Improvement in Clinical Outcomes in Underrepresented Youth with Type 1 Diabetes in an Intensive Community-Based Intervention.
Great, thank you, Alka, and thanks everyone. So in terms of background, we know that youth with chronic conditions, including type 1 diabetes, who coming from publicly insured and ethnically and racially diverse populations are typically and historically underrepresented in research. We also know that there are very few interventions that target social determinants of health in these particular patients, despite the documented impact of social determinants of health on diabetes, as well as utilization. So the Novel Interventions in Children's Healthcare, or NICH, was a program that was developed at Oregon Health and Sciences University. And this is a systems community-based intervention that targets social determinants of health. Just briefly, the NICH program supports families of children with complex medical conditions who also experience social stressors. And in this program, families are assigned a trained interventionist who serves as an advocate and liaison. And what the ITs do is they build relationships and they assist the families with skills building. They help families navigate medical care as well as daily tasks. And these navigators are available 24/7. And the usual time a family spends in the program is about 12 months. So what we did in the research project here is that we wanted to look at the first participants that UCSF enrolled in the NICH program who had type 1 diabetes, to look at their demographics and also look at some preliminary outcomes. So the eligibility criteria for our research study were those youth with type 1 diabetes who were eligible for NICH. And NICH eligibility at the time that they were enrolled included having more than one social determinant of health, as well as more than one of the following. So greater than one DKA, or diabetes ketoacidosis episode, or hospitalization, hemoglobin A1C greater than 14%, greater than 2 emergency room visits, or greater than 2 missed clinic visits in the last year. And we included in this particular analysis youth who were enrolled in NICH for more than 6 months at the time we did the data analysis. So the data we collected do include A1C, includes the use of continuous glucose monitoring, or CGM, which is a technology that's known to improve glycemic control in youth with type 1 diabetes. We also looked at the number of DKA events and hospital days. And we looked at, compared the time prior to enrollment to the time after enrollment in equal time periods up to 1 year, and then used paired t-tests to compare the changes in all of those outcomes. So you can see in table 1, I'm going to point out a couple of characteristics of our population of 18 youth with type 1 diabetes enrolled in NICH here at UCSF. So average age was about 15, and I'll just point out that this was a pretty diverse population in terms of race and ethnic background. So 61% were Black and 28% identified as Latinx. And you'll notice that 94%, or essentially almost all, except for one of our families, had public insurance. Regarding the primary caregivers, just wanted to highlight that although most were English speaking, there are a pretty fair number of patients who are Spanish speaking in terms of the parents or caregivers, and the education level varied from anywhere from having no high school degree to having only one of the caregivers having a four-year college degree. In figure 1, some of the common social stressors are highlighted here. A fair percentage, 27% or so, had difficulty paying for rent and mortgage, and also difficulty paying for food. And about 5 or 6% actually were experiencing unstable housing or homelessness. In figure 2 are our main diabetes outcomes that we looked at for these particular participants. And you'll see in the first part of figure 2, the change in hemoglobin A1C before NICH in blue compared to participation during NICH in orange. And you can see that there was a statistically significant decrease in A1C by 1.1%. Still high, still above target, but at least a decrease. And continuous glucose monitoring use increased significantly from 33% to 72%. In figure 3, I just want to highlight that looking at some of these outcomes, if we look at the percentage of youth in our population who had reduction or improvement in A1C, it was 72%, and 44% had a reduction in DKA events. In the analysis, there was no change in hospital days, but again, this is early analysis with just a small cohort. So in conclusion, what we were able to see is that enrollment of publicly insured and ethnically and racially diverse youth who are living with type 1 diabetes diabetes in research is feasible. And this is despite having limited interventional studies on these populations in the past. Our youth in niche with type 1 diabetes from these underrepresented populations did experience improvement in glycemic outcomes and increased use of technology during their participation. And our ongoing and future studies, of course, are following more participants over time, but we're also looking at hospitalization costs as well as utilization to understand the impact of niche on the hospital system. So grateful for all of our participants. Our ITs, our interventions are listed in the acknowledgements, and the research arm of niche was funded by a grant from the Helmsley Charitable Trust. So thanks very much.
Thank you, Janice. That was fantastic. Anyone have questions?
I have a question.
Great.
Sure.
Thanks for your presentation. This is really interesting. And I'm curious, since this is a pretty small sample, so the mean A1C decrease was fairly small, but
Yes.
I don't know if you know off the top of your head, like, were there people who had really substantial decreases in A1C, and what did you all notice more qualitatively about what the sense was of what, like, were those, I guess I'm wondering, did engaging with the program more, was that associated with larger A1C decreases? No, totally understanding this is a small sample and you're not.
No,
making
absolutely.
representative
No.
comments.
Yeah, absolutely. So we do have, I mean, if you were to track individual participants, you could see variation, and there were certainly, you know, those who had dramatic improvement if you were to follow individual A1Cs and look at it like in a spaghetti plot method. I will have to say that, yes, it's a modest change in the sense that no one is reaching their target of less than 7. However, a 1.1 decrease in A1C is pretty significant. I mean, clinical trials of many things are looking at a 0.5 decrease in A1C over the course of an intervention. So the change is great, but yes, we have a long way to go. Regarding qualitative, that's in process now. We are in the process of contacting these families, doing some in-depth semi-structured interviews to really understand what worked really well. And then I think larger numbers over time will tell us. I should also mention this research that I'm presenting is just the patients with type 1 diabetes. Niche actually serves kids with many other chronic conditions as well. And so that will be interesting moving forward. I mean, A1C and CGM use is nice for everyone with diabetes, but I think the experience in the program and hospital utilization as outcomes are going to be a nice way to look at kids who have a bunch of different conditions moving forward to really understand the impact of the program on many different disease conditions.
Thank you, Janice. That was really exciting.
Thanks.
In the interest of time, we're going to move on to the next poster, and that is poster number 20, presented by Sohini Halder. And the title is Addressing Food Insecurity in the Emergency Department with the Discharge Navigator Food Access Platform.
Hi, everyone. It's great to be here. So today I'll be presenting on the Discharge Navigator Food Access Platform that just recently launched, which is very exciting. So first, to give you all some background, about 1 in 4 SF residents are currently at risk of hunger and food insecurity due to low income. And during the pandemic, we saw a lot of food resources such as CalFresh and the SF Marin Food Bank were being substantially increased in their usage. And as you may know, at SF General Hospital, the patients that we serve, especially the folks that we see at the ED, are at high risk of experiencing access issues for food, substance use treatment, housing, and others. And so the Acute Care Innovation Center had previously already developed some tools to provide patients with resource handouts that would be printed alongside their discharge paperwork, especially in times when our social work team is overburdened with caseloads. So my goal was to just expand on this project and develop a specific tool to address food insecurity. So for methods, I knew that I really wanted to center grassroots community work and knowledge in the development of this project. So I reached out to multiple employees at the SF Department of Public Health and the Tenderloin Neighborhood Development Corporation. And through these interviews with organizational leaders and analyzing ED patient data, I designed and implemented this food tool. So the second column that you see in yellow has some stats for our ED patient population. Many of our patients are on Medi-Cal or are uninsured.
25% or so are unhoused, and we have diverse racial and ethnic backgrounds represented. Additionally, most of our ED patients primarily reside within that darker blue area on that map at the top, and this actually informed which SF neighborhoods I focused on when building out the tool. And it also got me thinking about accessibility issues related to public transportation to these food resource sites. So now I want to turn your attention to the third column, which shows the actual discharge navigator tool, which I coded through Bubble. And once you click on the food insecurity tool, there's 3 questions that will guide you throughout. So number 1 is, what kind of food support is the patient actually seeking? And there's options for the drop down for hot daily meals, grocery pantry items, emergency food access, or CalFresh vouchers, Meals on Wheels. I also learned through the Tenderloin Corporation that folks often feel a lack of agency when they're directed to food and pantry resources and they have no choice in the items that they select. So CalFresh vouchers are great ways to increase choice, as well as this asking the patient specifically what they'd like. The second question directs you to see if the patient is over the age of 60, since some resources are catered specifically to older adults. And number 3, what SF neighborhood does the patient primarily reside in? I tailor the dropdown to focus on that map up above. And so we have options for a Tenderloin south of Market Region, the Mission, Chinatown, Bayview Hunters Point, and the Western Edition. So for results, you can see that the tool compiles a list of 4 to 5 best fit resources given the patient's demographics. You can scroll through and you can select the handout PDF. And in terms of accessibility, which we thought about a lot during the design process, all of the handouts are created to be read at a 5th grade reading level, and there's 5 languages it's available in: English, Spanish, Mandarin, Cantonese, and Tagalog. And each handout comes with a screenshot of the Google Maps that shows the cross streets. And I actually included a new feature that shows the main Muni routes that basically direct you to this food resource site. Other info like possible ID requirements or registration are also included. For the clinician side, the website actually lists out dot phrases that you can use to print out the handouts during the discharge paperwork. And for the public, this is all publicly accessible, so anyone in SF can access this site. We launched on August 3rd, and our evaluation data for the first month shows 69 and counting page clicks, which have been pretty consistent throughout the month, which is very exciting. And so far, we only have Google Analytics data, but we're working on obtaining dot phrase usage data, and future evaluation protocol is going to include designing a closed loop referral study to see how many of these resources are actually reached after referral, and conducting patient interviews to understand the user experience. And so I'd just like to end with some conclusions and takeaways. First, I think it's so important to incorporate tools like this into medical education and training. When we see patients that have these social needs, food insecurity should make it onto the problem list, and then there should also be ways to start addressing that. I presented this tool to the EM resident conference in hopes to kind of start that process. Secondly, this kind of work should not be done and could not be done without consulting community partners. So when we build out tools like this, I learned that it's very important to make sure the tool is community supported. Third, digital tools like this require rapid cycle feedback. And so there's already a ton of things that I know I want to change and improve upon in the next iteration. Like I want to add the Excelsior region as a drop-down option and also add community gardening as an option. And lastly, it's been very humbling for me to think about how to center patient agency, accessibility, and accuracy in these tools so that we do right by our patients. And I just want to acknowledge the Acute Care Innovation Center for all their support and mentorship through this. And with that, thank you so much. I'd love to take any questions.
That was fantastic. Very inspirational.
Oh, thank you.
Does anyone have any questions for Sohini?
Yeah, hi. Thank you so much, Paula Fleischer from the CTSI Community Engagement Program. Really inspired also by your work, and wonder how the community organizations have been receiving this opportunity and participating in the QI process at all. Yeah, and then any next steps with or lessons learned about the community engagement piece of this.
Yeah, I love that question. Thank you so much for that. So I did try to incorporate different community partners. So I interviewed multiple employees from the SFDPH, and as well as talked to some leaders through the TNDC, the Tenderloin Corporation, and that they were so helpful. They really emphasized the importance of putting cross streets on the handouts, and also the bus routes. That new feature was directly inspired by our community partners. And in terms of next steps for your question, I really would like to get even more community partners that we're referring out to involved in this kind of next iterative cycle of that rapid cycle feedback I was talking about. And so I'm really hoping that this kind of next few steps, in addition to patient user interviews, will also include potentially interviews or some sort of other QI implementation for these community partners to see like what's working and what's not. And I think that, you know, one of the things that we've had to work on is we've recruited some undergrad volunteers to do a quarterly assessment of if the information on these resource handouts is even accurate. Because the thing with food resources, as opposed to like housing resources or other sorts of resources, is that food resources are changing all the time in the city. And what we put up one quarter might not be true or accurate the next quarter. And so we're trying to figure out ways to get our undergrad volunteers, help them out with that process, and also figure out how to incorporate the community in that feedback. But I'm always very open to feedback and suggestions on that as well. Thank you.
Wonderful. Oh, wonderful. Thank you.
Thank you. Can I ask one quick question? And that's whether you can share the coding of this, since it was done in Epic, with other San Francisco-based users of Epic to really help identify the needs and also, you know, utilize some of these navigation tools that you've created. So UCSF would be very interested in Ryan to share this tool.
Yeah, so I mean, the eDrive is like a UCSF-based platform, so anyone can access it. In terms of the coding of the website itself, I use this platform called Bubble. It's like a no-code coding platform. It still was really hard, as you can imagine. And then in terms of your question about the dot phrases, that I will have to look more into. The portion that I worked on was creating the actual dot phrases, and then my resident mentor, Dr. Alyssa Nip, actually handled sending the entire list of all the dot phrases for each handout in the 5 languages over to whoever is in charge of working on that at Epic. I'm sorry, I don't know more detail than that, but I can certainly find out for you.
Thank you.
Of course.
Okay, thank you so much. Let's move to the next poster, and that's poster number 56, presented by Denise Rubalcaba. Sorry if I didn't say that correctly. And the title is Providing Integrative Healthcare and Social Support for Safety Net Patients with Chronic Pain, Evaluation of a Group-Based Telehealth Program.
You pronounced it correctly. You did great. Thank you, Olga. So yes, my name is Denise Rubalcaba, and I'm from the UCSF Osher Center for Integrative Health. And today I'll be discussing a program that was adapted from the Integrative Pain Management Program, that is the IPMP program. This program was originally developed in 2016 at the Tom Waddell Clinic by Tom Waddell staff. And this was in collaboration with Dr. Maria Chow, also of the UCSF Osher Center. Due to the pandemic, we transitioned the IPMP program to a telehealth version with the question of if this version, a telehealth version, could address social isolation and pain management at a primary care safety net clinic. The telehealth version of the program is called TIPMP, Telehealth IPMP, and it was facilitated at Tom Waddell as well. The program was designed for patients with chronic pain. In order to be eligible for the program, patients had to have chronic pain, be within the San Francisco Health Network, and be referred by their primary care providers. And the program itself, TIPMP, was a 10-week program, and we provided sessions of multimodal integrative treatments. These include pain education, mindfulness, self-massage, and more treatments to support pain management. We implemented 3 cohorts of the program. 35 patients participated in at least 1 session. This was a mixed method study, and the data we are using today is from 20 patients that participated in focus groups, as well as 15 patients that completed pre and post surveys. In figure 2, we can see here that this group of 15 individuals was very diverse racially, and there were also varying levels of education. And our sample size was primarily women. And in terms of pain, they also varied in terms of chronic pain management as well as diagnoses. Moving on to the results, in the past, we collected much qualitative data showing that in-person groups provide beneficial social support for people with pain. We were not certain if an online version of this program could have similar effects. And in fact, this program was very beneficial for patients. Briefly, in the results, we can see some qualitative findings as well as quantitative results. Some of the main themes that came up in our qualitative data include theme 1, TIPMP provides community and social support. One patient shared, I came into the group as a naysayer, sort of. Much to my great revelation, one of the things it provided was support from the people who work here and community from the people who attend. And that makes a huge difference. You're not suffering alone in silence in your room anymore. In theme 2, we see that both an in-person and virtual version of this program is necessary. Theme 2 is offering both virtual and in-person groups can expand the reach and improve patient access. Here, a patient shared, I think that a Zoom group is good to have for some people, but I don't really feel connected with people. He goes on to say, I kind of need to be in a room with somebody, feeling their energy and being able to look at them. So it is clear that some people really want to be in person. Moving on to our quantitative findings, in figure 1, we see pre and post changes in patient-reported outcomes. I do want to highlight again that this was a small sample, so our N is 15, and this is a pilot study. That being said, we did see some improvements in patient outcomes. The bolded outcomes are those that are statistically significant in the table, and these include physical function as well as anxiety. So this program was able to address both physical and mental health. In conclusion, the TIPMP program is a feasible method to offer multimodal pain treatments with social support, and an in-person as well as an online version is necessary. And we are excited to announce that we will be testing the in-person version on a larger scale in both English and Spanish at 2 San Francisco Health Network clinics. And thank you to everyone who assisted in this program, as well as thank you to all of you today.
It was great. Thank you so much, Denise. It's open for questions. Denise, do you, so this is great preliminary data that the telehealth version works. And I know you are planning an in-person intervention now that you're going to be studying, and that's in a pre-post, like a single arm way, or are you going to be randomizing people to any other intervention at the same time?
Yes, we will be providing treatments of acupuncture for one group and another group won't be receiving acupuncture. So that's also in a sense to test this acupuncture treatment. And then these patients that participated in this program also received acupuncture and massage while in the clinic. So they were able to come in whenever they were able to. They also
Can I add on to that answer, Denise?
Yeah, absolutely, Ariana.
So then the next version of the study will be a 4-arm randomized trial. So people will either get usual care, just acupuncture, and the usual care, acupuncture, this integrative pain management program, or both acupuncture and the group pain management program together. So it will, it's partly focused on sort of seeing which elements of the program are most effective. And then also we'll be doing a much more in-depth look at the social isolation and social support pieces.
Terrific.
Yeah, and I do want to note that this program is impactful beyond chronic pain. One of our patients expressed that he formerly didn't know that he was harboring a lot of anger. And through the mindfulness and meditation treatments and techniques, he was able to hone in on that and create a better relationship with his daughter as well as his grandchildren. So this was social connection beyond just other individuals within the group. I thought that was incredibly impactful, and I'm very passionate about this. Thank you.
Fantastic. Other questions, discussion? Okay, thank you. We'll go to our next poster, number 39, presented by Christopher Montgomery. And the title is The Humanistic Charting Initiative, Standardizing a Patient, Person, and Voice into the Electronic Medical Record.
So yes, hello everyone. My name is Chris, and I'm a current MS4 here at UCSF. The title of this poster, as you said, is Humanistic Charting, Standardizing a Patient's Person and Voice into the Electronic Medical Record. This is an initiative that was inspired here at UCSF and actually came to life in New York City in the health and hospital system. I'd like to start off by first reading to you a quote from the qualitative portion of this study. This came from an amazing 40-year-old mother and advocate who has a high school education and is living with sickle cell disease. When I asked her to tell me about herself, what she would like a provider to know about her, she said, "I'm a daughter to 2 caring parents, a very active family member and community member. I'm a wife and a mother, a producer and on-air personality, and just so happen to be wrapped in sickly goodness all around. Please know my goal is to make it out of here as intact as I possibly can so that I can get home to my girls, and I guess my husband too." When I asked her if she thinks, is this how her healthcare provider would describe her, she answered immediately no. Out of the 38 participants in the qualitative portion of this study, only 2 were able to answer yes to that question. I then asked her, how do you believe your healthcare provider would describe you? Her answer, I think they see me and my community as trouble, as drug seekers, which is crazy. And they see us as not worth it. When people can look you in the face, and I actually had a doctor say to me, I help you because I know you're real. You're not here for the drugs. I know you're not like the rest of them. Who is the rest of them? Because if you're talking about the sickle cell community, I am the rest of them. I'm just like them. While this response seems to orient itself to an individual's lived experience, if we were to incrementally break it down and analyze the reality of this type of event even being able to happen, we would move beyond the comfortability we have or the thought and thinking that this is just subjective, and really objectively see how ingrained into and maintained in our healthcare system this type of experience and reality actually is. Which leads me to a few important questions. Do we know our patients? Is information about their life outside of the healthcare setting important? Is that information consistently available or always asked of the patient? And if not, what assumptions, categorizations, or expectations about a patient are used in the clinical setting and also the care decision-making process? Now, with that entire introductory framework in mind, the goal of this project was to develop a process and systems-oriented tool effective in documenting and presenting a patient's person to healthcare providers through the electronic medical record. The most important and complex word in that goal is the term person. Utilizing community-based participatory research principles, the study was designed in a 3-phase process. In phase 1, we call patient voice, where we conducted 38 interviews with patients from 6 different hospitals across New York City. Using semi-structured analysis, we had 4 core themes that saturated, describing what patients find important for their healthcare providers to know about their life outside the healthcare setting, or what they call their person. These sections included a self-written narrative, enabling patients to describe and present themselves, health goals, making sure that regardless of having that good doctor that asked the question, hey, what did you want to talk about today? That their health-related needs are already known and consistently available in the electronic medical record. The third section, care preferences. What language do they prefer? Are interpreter services needed? How do they learn best? Are there preferred treatments? How can we improve the care? And lastly, what we call variation, or how important life circumstances in their current and their past reality can be documented and known and seen if that sort of impacts their health. Phase 2 has been completed, and we call this patient choice. Through 6 focus groups at 6 different hospitals, patients actually designed the actual tool that's now been created, as described by one of the participants, a tool designed by us and for us, which leads us to phase 3. The tool is currently being piloted or in the process of planning pilots in New York City at Bellevue, Harlem, and Jacobi hospitals, as well as correctional health at Rikers Island. We also last week received IRB approval here at the UCSF to pilot this in the emergency department at Parnassus. This tool is not the final version. It's a representation of patient creation, a first draft of a concept focused on enabling the tailoring of care to meet the needs of the person, rather than that sort of constructed expectation of a patient. So thank you for your time. And if interested, the QR code at the bottom right of this will take you to a few more amazing stories collected throughout this time in this interview. Quick shout out to everyone. Thank you. Thank you. That's everything.
That was amazing. Very inspiring. All of these talks have been really inspirational. Thank you for showing us the power of community and the patient voice here. And any questions from the audience before I ask my own? No. So my question was, how would this work for patients with limited English proficiency in terms of documenting these into the record, and tell me how you're operationalizing that?
Yeah, so the goal is for the same way we don't want labs from 3, 6, 7, 10 months ago, right? We want it up to date. The goal is for this to remain in the patient's control through an external software. And the next really big part of this study is validating the concept. And there's enormous support for it, but it's really sort of focused on primarily collecting data to actually academically prove that it works and it benefits. What we're going to eventually do and what we really expect is commitment from a system. I imagine the simplicity of ordering an interpreter services, right? Where a phone call could be made, updated external from the EMR, which is legal. And then, or for example, another phone call could be ordered by a provider to collect this information and have it available by staff who can fill it out with the patient. Other than that, there's a number of different possibilities, but right now this is the first iteration of a new concept where we empower patients to tell us what they need in a standardized manner, rather than just patient-centered care, which is amazing, where we put really such a big emphasis on the physician collecting that information.
Thank you, Christopher. There is a question in the chat, but I'm going to have you answer that in the chat itself so we can go to the last speaker. I'm sorry. Just in interest of time, I have to move on to the final poster. Is presented by Stephanie Wong, poster number 77, Preferences and Perspectives of Black Male Barbershop Patrons on Receiving Healthcare in Non-Traditional Settings.
Hello everyone, I'm Stephanie, and I'll just get right into it. So in terms of background, non-Hispanic Black men experience a disproportionate rate of morbidity and mortality from hypertension in the US compared to other groups. So in response to these disparities, there are a lot of studies that have shown efficacy of community-based health outreach in settings not traditionally utilized for healthcare interventions. You may know there was a landmark cluster RCT for Black men with uncontrolled hypertension done in LA that demonstrated that health promotion by trained barbers resulted in a clinically significant blood pressure reduction in this population. And furthermore, there was a greater reduction in those participants who had both barber-led health promotion and pharmacist-led interventions, where 64% of participants reached the target blood pressure goal. And it also resulted in a statistically significant 21.6 point decrease in blood pressure compared to those who had barber-led health promotions only. So this led us to wonder if non-traditional healthcare interventions could be made into a sustainable, more broad-scale model in real-world settings. To note, the patrons were given financial incentives, which may allow for more frequency to follow up and adherence. So to better understand if this healthcare model was worth pursuing in the first place and is feasible without any financial incentives, we need to hear the opinions and perspectives from the actual community that we're targeting. So we created this survey-based study to explore the perspectives and preferences of these Black male barbershop patrons regarding healthcare provided in non-traditional settings. So we had a setup at the Chicago 2 barbershop in San Francisco, and we had a station in the back where we or the barbers who were trained would offer free blood pressure screenings. And regardless of whether or not they participated in that, we asked them to take our survey asking about barriers to receiving healthcare, where they prefer to get their healthcare, and also why. So of the 31 surveys, 17 of them were identified as non-Hispanic Black males, and we use this for data analysis. And as you can see, we found that 81% of participants agreed or strongly agreed that they would like to receive services from normal clinics. The pharmacy and home were the next highest in terms of preference. And the non-traditional settings had less than 50% positive response rates, and they also had a greater fraction of negative response rates. So interestingly, our overall results suggest a substantial skepticism. And in the free response section, they often cited privacy or quality of care, sanitation, and HIPAA violations as concerns. So one potential reason for this skepticism is just lack of familiarity with these clinics. However, the evidence out there demonstrating that non-traditional healthcare settings are more culturally sensitive and accessible, this evidence has increased over the years. So many of these concerns can be addressed if the healthcare community decides to pursue these methods of reaching marginalized communities and work to perfect them. So hopefully when the public is more exposed to these sites, public acceptance may increase, paving the way for successful expansion. As for barriers to receiving healthcare, insurance coverage and cost of visits were the most commonly reported barriers. It's a common finding to see costs cited as the major barrier to receiving services. And particularly the uninsured rate is second highest in Black Americans compared to other groups. Second to cost, participants in the study reported the lack of a close relationship with their provider as a significant barrier to receiving healthcare. So this has also been an observed factor preventing access to healthcare among historically marginalized groups. So with implementation of non-traditional clinics, hopefully this concern regarding relationships with providers can be addressed. So in conclusion, we're just reporting what we found, perspectives and preferences of Black male barbershops in regards to where they want to receive healthcare. Though our respondents generally express reservations and distrust in these models, more conversations are really needed to increase acceptability. And that is it. Thank you for listening.
Thank you so much, Stephanie. That was wonderful. Any questions? I have a question. I'm really surprised with your results, and I think you might have been too. And I wonder if there is any other demographic information you could share about the men who took part in your survey. And I'm wondering if they were connected to healthcare already, had a strong PCP relationship, and that's why that they preferred more traditional settings for their care, and maybe it's slightly different from other men who are barbershop patrons.
We did talk about this briefly. To our surprise, a good handful of them said that they didn't have a PCP, but we didn't really calculate or like stratify the data about like who had a PCP and who responded saying they prefer clinics or not. Something else that came to mind was just the patient population and the location that we're in. So SF tends to be more accepting of like diverse like populations reaching out to marginalized communities. So overall, the society in SF is very specific. We are speculating that outside of SF, the responses may be completely different.
Perfect. Any last questions? We're a little bit over the hour. Well, I want to thank you all for your attention, and I mostly want to thank the investigators and speakers for their very inspiring and just really inspirational work. Thank you. Have a great rest of your Friday.
Thank you, everyone.